Today's webinar is all about the future of lymphoma treatment. We chose this topic because it's World Lymphoma Awareness Day, and we wanted to highlight some exciting research that's being done in lymphoma. We are very excited to have Dr. Cortese share his expertise on this topic with us today. Dr. Matthew Cortese is a lymphoma specialist and an assistant professor of oncology and cancer genetics and genomics at Roswell Park Comprehensive Cancer Center. He treats all forms of lymphoma but has a primary clinical and research focus in CLL and non-Hodgkin lymphoma. And with that, I will turn it over to Dr. Cortese for his presentation.
Thank you so much, Hannah, and thank you, HealthTree and everyone, for putting on this amazing event on a very auspicious day. We're going to talk about how we're doing so far with lymphomas, and I think more importantly, how we're going to be doing in the near future and even distant future. We want to make these blood cancers and all their blood cancers history over time. I just want to confirm you can see my screen okay?
Yep, looks perfect.
Sounds good. With that, we'll get started. Here are my disclosures. So first, I'd like to talk a little bit about precision medicine in general. So this is basically this buzz term you might hear used pretty exhaustively throughout, all of medical fields. But I think it's critically important to be mindful of some of these general approaches and the reason for doing lots and lots of specialty research, spending lots of money making new treatments. I'll try to impress upon y'all the importance of precision medicine approaches, especially when it comes to lymphomas. Talk a little bit about lymphomas in general, and then I'll talk about a little bit more brass tacks on how precision medicine approaches are being incorporated into lymphoma treatments and new experiments, and then the treatments of tomorrow and how we're going to make them reality. So with that, I'd like to just talk a little bit about precision medicine. So this is a dynamic, comprehensive, and iterative process, right? So of course, requires patients, requires investigators, requires laboratory personnel, requires lots and lots of resources coordinated together and orchestrated really carefully to try to answer meaningful questions. Multiple data elements are involved, so that basic science, clinical, and population level data streams. We need digital support structures, of course. We have these omics technologies I'll talk about, which I have the privilege of leading here at Roswell Park in Buffalo. We'll talk about kind of advanced imaging and computational techniques as well. And really, we have to make this an iterative process. We have to keep reinventing, keep seeing if this has been a beneficial change, if this has been a model that's working or not working, as we see how actual folks are doing in real life. And of course, this all has to be contained in an ethical and legal framework which protects patients' data, protects academic property and hard work. It takes years and years of work, I'm finding out, to get these things published and across the finish line, and more importantly, protect patients' health. So who cares? So why do we talk about precision medicine approaches in general? I think we can all say that a tailored suit might fit a little bit better than something you would buy off the shelf if you're going to a fancy wedding, for example. Medicine, you can argue, is a little more important than looking sharp for a wedding. And so we need tailored treatments that can maximize the benefit for patients and improve safety. I think that's the key. Of course, we also want to reduce medical errors. We want to reduce costs and copays. And of course, we want to help people live a better, healthier life with fewer toxicities and side effects. And that's really a major incentive by itself. But I'll continue shamelessly advocating for precision medicine here. So the other important avenue, of course, is to save lives, right? So new treatments, new cures. If we can predict with high precision how someone's immune system is functioning, or what kind of molecular features their blood cancers can, challenge us with and allow them to grow, then we can be better at targeting them, learning how and why certain treatments fail our patients, and how to do better the next time, right? So our burgeoning knowledge of immunology and molecular biology, I'll try to convince you of today, really is kind of the sweet spot for developing more of these new treatments and potential cures, hopefully with fewer side effects. We also, of course, want to save money. We want to generally give the best care first, right? Healthy people are productive people. Relapses are expensive, of course, in the human cost, but they're also financially expensive, right? So you have to really prevent relapses, right? If we can treat people the best the first time around, then you may not need to you know have these horrible things called relapses that we all fear and want to do better at preventing outright. Um, One of the ways we can do that is to try to attempt to predict the future, or at least pick up very little disease. I'll talk to you about that again today as well. But there are new tests out there that basically can look at um, hidden signs of cancer in the molecular realm. I'm talking about circulating tumor DNA or single cell sequencing. Those kinds of things are coming, if not already here. And so if you can, look at how people have responded, say you can't see cancer in the traditional ways, but maybe we can find it in the molecular way, we can, eradicate that residual disease before patients ever have to experience any relapses. And then it should be number 5 really, but just for the sake of space, it's always better to lead, right? You don't want to be, wiped out as a laggard, falling behind your colleagues, especially in academic medicine and at NCI designated cancer center like Roswell and others. We really, really want to push to lead. And so precision medicine is at the forefront. I like to teach my students and fellows. It's like having glasses on or not having glasses on, right? You can see a lot more, at least I can, with my glasses on. And these molecular tools really help us see and refine things that really were completely hidden before. And it's a gold mine, frankly, for us researchers and doctors and for patients to learn new insights that were never ever described before using these new techniques. And we'll talk about how we're doing that lately here in a little bit. Before I do that, though, I just want to kind of go back to square one. So what are lymphomas? So lymphomas, we should know on Lymphoma Awareness Day, but these are a heterogeneous group of cancers, blood cancers, so to say, derived from lymphocytes. Lymphocytes are basically immune cells, which I'll show you in a moment. Lymphoma, the word itself, the etymology, comes indirectly from Greek. It was actually pure water in Latin, was lympha, and oma was Greek for tumor. So like sarcoma would be, say, a muscle, soft tissue kind of tumor, right? So this is a watery tumor, so to speak, liquid cancer. Lymphomas are 85% of the time, say someone says I have a lymphoma or I think I have a lymphoma, 85% of the time it's going to be of the B cell variety. B cells actually were so called because of the fact they were born in the bone marrow, but they actually tend to live in not only the bone marrow and the spleen, but also, of course, in the lymph nodes. T cells are so called because they were developed originally in the thymus, which is that primitive organ in the middle of all of our chests, especially when we're a baby. Really critically important for T cell differentiation development. These are cells that will really, I call them kind of the special forces, if you will, that do surgical strikes and kill precancerous cells throughout our bodies, say with skin cancers. They also are quarterbacks, and they really help all other forms of the immune system coordinate their attack. These CD4 cells, for example, are missing in patients with HIV and AIDS. So, very, very important and underrated and underappreciated. Natural killer cells are kind of like Batman, like my son would say. They are good at killing the bad guys, so to speak, and they're already turned on programmed to look for non-self kind of cells. Lymphoid malignancies, you'll hear a lot, is really a broader term because lymphomas are often, will include things like chronic lymphocytic leukemia or hairy cell leukemia. These are it's kind of a broader category. Leukemia, of course, means there's blood involvement, or usually bone marrow involvement, or almost always bone marrow involvement almost. And then plasma cell neoplasms like multiple myeloma, AL amyloidosis, other kinds of cancers with a lymphocyte origin, basically, their backstory. ALL, of course, would be a precursor kind of lymphoid malignancy. The discovery, so to speak, of lymphomas, of course, patients and people have had large morbid growths and tumors all over their body, since the beginning of life, I would imagine. But Dr. Thomas Hodgkin of the classic, Hodgkin or non-Hodgkin lymphomas, it was so labeled honorably after Dr. Thomas Hodgkin because he was the first really to apply light microscopy and some very primitive stains back in 1832 and published some of the first papers in this space. I'll convince you that Hodgkin lymphoma, really there's only one legit Hodgkin lymphoma. I count NLPHL histologically looks like Hodgkin lymphoma, but really behaves more like a follicular lymphoma. I won't worry you too much with that, but just know it's a thing. So there's really, 110 other kinds of non-Hodgkin lymphoma, which I'll show you in a moment. Tons of progress, especially over the last 60 years as we developed immunohistochemical stains. But this is really what Dr. Hodgkin had seen in part, way back when. You can see these really weird cells. This is called a Reed-Sternberg cell. And actually, there's only one malignant cell in this picture. It's actually, these classic owl's eye. Just tells you how complicated these are. And so the large bulk of a Hodgkin lymphoma tumor mass, for example, these are actually corrupted, co-opted other immune cells that are just kind of hanging around the cancerous cell, and they form this kind of protective cocoon around the Hodgkin cells. And I think I briefly touch on checkpoint inhibitors, but these are a form of treatment which have completely improved the standard of care for patients with Hodgkin lymphoma. Checkpoint inhibitors basically can turn these other immune cells that hang around the malignant cell and actually turn them again into friendly anti-tumor cells and kill the cancer. So those are new treatments and new approaches now. Out this last year, really, FDA approved Nivo-AVD, for example. This is just a brief timeline just for your reference, but just look at, kind of not much happening. Then you really see into the 70s and 80s. We start to identify some certain patterns of certain patients with collections of disease, and then we are better and better at subtyping these types of cancers, really by how they look under the microscope and using special stains. And then we start eventually, you'll see in just the tail end of this thing, we start using chromosomal changes and genetic testing to start breaking these types of lymphomas into smaller and smaller little subgroups, basically. So it gets very complicated very quickly. And I'll try to continue to make y'all more confused as I talk here intentionally. And then, of course, I'll be happy to answer questions at the end. Lymphoma tends to be a disease of the old, I can't say elderly very friendly, but the more experienced among us, except for things like Hodgkin lymphoma. It has this bimodal distribution. Most patients have non-Hodgkin lymphoma. It's the seventh highest cause of cancer and also cause of death as well. So still very, very prevalent as a collection of blood cancers. Here's again just kind of the demographics. So you can see that most mature non-Hodgkin lymphomas occur later in life, really into our 50s, 60s, 70s, but they can occur really at kind of any age. The notable exceptions would be Hodgkin lymphoma. Again, this bimodal distribution, classical type tends to occur kind of around my age, in the 30s or so, or a little younger, and then again into our 70s or so. So different distributions for different types of blood cancers, and actually can help us, predict what type of blood cancer someone's going to have when they come in and need care with us. These are kind of primitive graphs, but and again, I'll show you in more detail, but the most common form of lymphoma is diffuse large B-cell lymphoma. And then CLL and SLL kind of get lumped together. CLL is considered the most common form of leukemia, but again, it's a lymphoid malignancy. Often gets lumped together with small lymphocytic lymphoma. This is one of my main specialties. That's why I will talk about this a little bit more. And then the most common slow-growing or indolent form of lymphoma is follicular lymphoma. And you'll see that there are lots and lots of treatments available, really for all these lymphomas, but especially DLBCL and follicular lymphoma and CLL. Again, pharma companies have to make money, and they of course want to target, patient populations which have the greatest numbers of people. And I'll talk about a little bit why it's challenging to treat T-cell lymphomas. They're not only biologically, very aggressive and heterogeneous, but they're also not very common. So to get people on clinical trials and to get funding is challenging. And that's one of the unmet needs we'll talk about at the very end. And there are all kinds of other lymphomas as well that present really variably, and I'll talk about those now. So this is the latest version. This is our gold standard, at least at Roswell Park, is the World Health Organization 5th edition classification of blood cancers. This is the lymphoma edition. But by my count, there are 49 mature B-cell lymphomas, 2 Hodgkins, 47 of them are going to be considered non-Hodgkin lymphomas. And they range from, and here's kind of another summary page, but they go from indolent, things like monoclonal B-cell lymphocytosis, which is what I often call the polyp of the immune system, just like if you go through a colonoscopy and you find a little precancerous polyp. MBL it's kind of an immune equivalent, similarly to MGUS, monoclonal gammopathy of uncertain significance. Oftentimes will get kind of lumped into this kind of precancerous group. And then it can range from that to things like Burkitt lymphoma, which are the fastest growing cancers, period. They can double in a day. So it's emergency to get people on urgent chemotherapy for these kinds of cancers, and those are curable 90% of the time. Indolent lymphomas tend to not be curable. The reason why is something that we're working very actively on to try to figure out, why do they hide, basically from treatments. Part of it's because chemo and immunotherapy selectively will kill more effectively rapidly dividing cells. So by and large, most of our aggressive B cell lymphomas are curable with some form of chemoimmunotherapy. And then we'll talk about cell therapy and other immune therapies a little bit as well. Indolent, slow-growing lymphomas tend to be incurable, but highly manageable. And there are the new treatments we have, things like cell therapies. We're working on trying to cure more of these patients, and some might already be cured now. We just don't have quite enough follow-up time yet on our trials. So things like follicular lymphoma, patients may never relapse again, frankly, after some of these treatments. So we'll see. Just briefly about T-cell lymphomas, 39 subtypes. Again, this is all based on largely histology, right? Looking under the microscope, slapping some fancy paints, essentially, immunohistochemical stains on tumor cells, and then looking into the microscope, looking at different patterns, looking at different kind of subtypes of, different origin of these lymphomas. But, honestly, we probably have 6 to 10 times more actual lymphomas if we really look into the molecular features of these things. So just to let you know, this is where we stand as of right now, actually 2022. But this is going to probably rapidly grow as we gain a better appreciation for the complexity of these cancers. So I always say that, the cure for cancer, if I hear someone say without the S at the end of cancers, right, they don't really know, frankly, oncology as much as I'd like them. We really have to start talking about cures for cancers, right, in the very plural sense, as more of a process than, say, one tablet, that can take care of all these things together. So, again, this is just my breakdown of T-cell lymphomas by aggressive or indolent. You'll see many, many more of these subtypes are considered aggressive, but there certainly are a handful of fairly common indolent or slower growing T-cell lymphomas, especially in the skin. Cutaneous T-cell lymphomas generally are indolent, and things like TLGL and others, often you can watch and wait for years. So how do lymphomas present? As you can tell, there's many, many subtypes of lymphoma. So they can present highly variably, which is kind of scary for folks. I understand that. Generally, though, if they're going to be a fast-growing type of blood cancer, they tend to cause B symptoms. B symptoms are inflammatory symptoms, really characterized by a fever that's not typically associated with an infection. Talking about weight loss, really over 10% of patients' body weights over about 6 months or less. Night sweats, which are often drenching night sweats, not really that kind of the damp, as I call it, for a lot of my folks with CLL, for example, who are on surveillance, or follicular lymphoma without very much burden of disease. It's very common to have some detectable disease that's not growing much. People can live a normal or close to normal life, right? Granted, with some form of anxiety, which I'm hoping to dispel with some knowledge today, if I can. And but oftentimes there's like low level, the temperature in the room is a little bit hot. My wife is not hot, but I'm sweating a little bit, but it doesn't bother me. It doesn't drench my shirt. I don't have to change my bed sheets, right? The typical B symptom that would require treatment, even for indolent lymphomas, is often drenching, right? Like soaked my shirt, whole bed, I have to change the sheet, and that can kind of sneak up on people, frankly, over time. And if it ever gets to that level, that would be a reason for treatment, for example, for slow-growing lymphomas. Palpable, this means you can feel them on exam. So oftentimes people will come in with bumps and lumps, and that's how lymphomas are ultimately diagnosed. And they can be, growing very rapidly, or excuse me, they can grow very slowly, and they can be huge, or they can be very, very small, like a little grain of rice. It's important to track those over time. That's why we ask patients to come and see us and have physical exams. There are some emergencies, of course, that we have to look at. Things like tumor lysis syndrome. As you can imagine, if you have a very large lymph node, this is a pretty impressive one, submandibular node here under the jaw, If this starts causing airway obstruction or vascular compromise, like, blocks this poor guy's, jugular vein in the neck, causes a headache, vision problems, SVC syndrome, we'd call that, for example. Those would be reasons to treat right away. I would not want people to sit at home with anything like this at all. It's an urgent workup, urgent treatment. Don't ignore these things. God forbid you have them. Things like malignant effusions, so if there's cancer cells actually in the fluid pockets around the lungs, around the heart, also can be an urgent reason to treat someone and work them up quickly. Lymphomas, again, B for bone marrow. They can, some of these lymphomas can actually live in the bone marrow and squish and push on other healthy cells. And, the factory basically gets, imagine you're on an assembly line and you're trying to manufacture widgets and you have this annoying coworker who's malignant, right, is pushing things around, flicking buttons, getting in your way, right? You're not going to have a very healthy bone marrow to start making healthy blood cells. And lymphomas, of course, can do the same thing. Chemotherapy, of course, or active treatments, even some targeted therapies can cause low white counts. So things like that, a fever with low white count is an emergency as well. There are weird things like hyperviscosity syndromes, lymphoplasmacytic lymphoma, more commonly than marginal zone lymphoma, can cause a high level of an IgM antibody, which can cause stickiness, can cause skin rashes, can cause neuropathy. These things can present very, very weirdly. Hyperviscosity syndrome would be a dramatic, accumulation, sludgy molasses-like consistency in the blood. Has to be treated very urgently, right? Or people can have strokes or heart failure, or things like that. And there can be weird other antibodies, right? These lymphomas can make antibodies, and those antibodies can, not always, but can, it's actually fairly uncommon, but I see a lot of it, and as do other doctors who treat lymphomas all the time, see weird complications, weird antiplatelet antibodies formed or anti-red cell antibodies causing, break apart of red cells. So if there are weird lab changes, weird symptoms, the lymphoma can always be implicated if we look hard enough, but not always. So it's just important to keep it on. In doctor speak, we call it our differential, right? We have to always consider the lymphoma might be affecting us in other weird ways, and we have to be, smart enough to recognize those things. I'm talking about us as docs, but as patients, just please, if you feel anything weird, just let your doctors know, and we can help you. Don't hide things. That's all I would ask. Going back into treatment now, so of course, for aggressive lymphomas, we're treating as soon as we recognize it's an aggressive lymphoma. We're going to recommend urgent treatment because we know it's going to get bad quick. If you look at just the time frame, right, it was chemotherapy. CHOP was actually born as kind of a main backbone for a lot of the aggressive lymphomas. Really started in the 1980s. The dean of my med school at SUNY Upstate in Syracuse, actually, I think knew the guy. He actually had lymphoma himself, gave himself CHOP, put himself in remission, basically, back in the 70s and 80s, basically. It's been our backbone, honestly, for 25 years plus, in some form or fashion, because it does work, right? But we do add now at least rituximab, and you can look at these kind of just papers just by glancing at them. But adding the first antibody to a chemo backbone was really not until 2002, so not that long ago, but as I'll convince you of, it's an eternity ago, actually, in terms of how much progress we've made so far, really over the last 20 years. So all that funding for the Human Genome Project, Roswell, I think, had one of the first 10 patients on that, has really propelled us into the future now, and I'll try to convince you that here. This is just one kind of already outdated figure from 2018 from Michael Wong's group. He's a mantle cell doc down there. So I took this figure because I love how it just shows the machinery of life. And when you think about blocking certain kinds of blood cancers with certain pills, so one of my favorites would be, say, a BTK inhibitor or BCL2 inhibitor, right? You can actually kind of throw a wrench in the gears of these growth pathways, but over time, the cancer can learn, right, or evolve and develop these acquired resistance mutations, we call it, right? Different ways of being. And it's basically like having a circuit, right? You shut the circuit off, but the darn cancer can rewire around that circuit over time. So you got to just always be aware, say you're on a pill-based treatment. They do work for a long time with very few side effects for most people. But cancers, just like in Jurassic Park, life can find a way, right? So you got to be aware that there are multiple other pathways that these cancer cells can use to circumvent and and get around our treatments. And that's why we'll talk about new combinations of treatments, especially using the immune system to clean up any residual cancer and get rid of this thing for good. We're learning much more also about how to modify, these transcription factors, these other very, very complicated. If you look up, say, in YouTube, be careful what you find out there. But if you look up, say, molecular biology, how life works, you'll see these amazing figures of how, genetics are truly regulated by other proteins and things that can block and open DNA, for example. And we're learning much more about how those processes work. And then we put all those things together. We make new treatments all the time. So there's a lot more that's still in the pipeline. But these are the broad themes for treating B-cell cancers here on one screen. I mentioned CLL. I've got a particular, axe to grind against CLL. That's a very weird immunosuppressive type of blood cell cancer. Very good modeling, honestly, just with peripheral blood. I'll show you on how to make immune therapies better, especially using targeted therapies with immune therapies and using them to their best effect. I've already added a couple, extra pages to this, but know that there's multiple ways of killing these cancer cells. T and NK cell therapies, and again, these are either already approved or about to be approved. T cell lymphomas, as I mentioned, there's I think it's the 39 subtypes of T cell lymphomas, right? In our latest classification, they're all treated a little bit differently, and our understanding is still quite primitive. We still often will give CHOP, for example, to many patients, or BVCHP, giving one extra treatment that targets the outside a little bit differently. We treat a lot of these T cell lymphomas very similarly to each other, but we know that they will behave differently, and basically we need to be better at this. But we do have some hope here and some targetable pathways as well for T cell lymphomas. So that's the standard stuff. Actually, that's what is already known. Now I want to dive a little bit into what we're going to do to make things even clearer and even more complicated, unfortunately, as we go. Fortunately, if you're a nerd like me who loves to do cancer research and dig into the details here, but it's very confusing. So please, at the end, put any questions or comments in the chat. I'm happy to try to answer as many as I can. But one thing I just want to say is that without patient participation, community participation, without this really detailed and ethical and legally sound collaboration between people with blood cancers who have these malignant cells and scientists to look at some of these things, and then we work together. If we do that, we can make great things happen. This is my protocol that I wrote at Roswell Park, which allows us to collect any just residual specimens. You're already going to get poked, for example, to get a routine blood count check. We could add an extra tube or 3 of blood, do all kinds of crazy science with it, and really we learn a lot. And I'll show you some of our initial payoff, so to speak, with that. One of the reasons that, one of the things I would advocate for would be just to always request, if someone asks for biospecimens or data, what are you going to be using it for, and what progress has been made so far? Like, is this worth our while collectively, right? And just important, I think, for some context, to always feel empowered to ask questions, but with an IRB approved research collection protocol, everything has good data security. In my opinion, biased opinion, the benefits far exceed the risks of donating specimens for science. And we honestly need help as translational researchers. We need to have pieces of the actual cancers to see how we're going to cook these things for the better and more tolerably. So again, precision medicine is this community-based approach, essentially. Multi-omics is one of the things I'm really most excited about from my own research career. And I think, frankly, this is part of the puzzle for curing cancers, as I mentioned. Multi-omics is defined as this integration of large data sets into one kind of comprehensive model. And it's really based on our understanding of what's referred to as the central dogma, right? So we know how, broadly speaking at least, and actually lots of detail, how life actually is wired and how our bodies really tick, right, at a fundamental level. So we look at the DNA sequences, then we look at the opening and closing of those DNA sequences. It's like you're reading a cookbook and you have like a sticky note covering, part of the ingredients, right? You're not going to make necessarily that part of the cocktail. Our life works the same way. Transcriptomics would be like, you're copying that cookbook and you're writing down the instructions on a little index card for future use, right? You're actually turning it from DNA into RNA. The RNA is then read and turned into functioning proteins or non-functioning proteins, as is the case oftentimes for mutations, for better or for worse. How those proteins interact with other molecules throughout the body. We can even call that interactomics. I didn't even put that in here yet. And then you look at the chemical changes that life requires and alters along its journey, and you can actually see how some of these chemicals, proteins, carbohydrates, lipids, for example, are changed basically or not changed, and how all these things really tie together. And I think most importantly, of course, is the phenomic, right? So how is this thing actually behaving? How does it look? And how can we treat it, right? So what surface markers, for example, can we target? Putting all of them together, this kind of pie in the sky dream is like panomics. And I think of it like, you're playing a song and you're playing all these different pipes on Pan's flute, this old, I think, Greek god, right? So you got to play the tune here to cure the cancer, so to speak, by putting all these omics together. This is just another look at multi-omics. So it's basically looking at lots and lots of molecular data streams coming together, looking at imaging, looking at how patients actually do, looking at demographic factors, things like age, gender, etc. All of these things can be combined into one really broadly holistic model in a very complicated but very cool way to leverage our new approaches, basically, right? This is, again, something that's never really been fully realized yet. We're just starting that in one project I'll show you in a bit. One of the first, and I think really kind of cool looks, at least lately, in molecular subclassification is going back to our most common form of lymphoma, so diffuse large B-cell lymphoma. This was actually a paper I saw when I was a fellow at Cleveland Clinic. It came out in the middle of the early part of that horrible COVID pandemic we just all survived through. Was not easy by any means, lost good people along the way. We'll talk about that another time, basically, but preventing infections, another big theme of active research and need. But looking basically back at breaking apart, again, our microscope view, so to speak, the very basic way to subclassify, say, large cell lymphoma. Traditionally, it was activated B cell type and then germinal center B cell, or non-GC and non-GC types, and then just a smattering of these unclassifiable ones in the middle. Use something called the Hans algorithm, not to bore you too much, but there's a way to just look at surface proteins by flow cytometry or by looking under the microscope, right? Things that have been done for 40 years now. But new techniques looking at genetic sequencing, I believe this was with RNA sequencing, clustering, basically, you can actually split large cell lymphoma into these invisible molecular subclusters of disease, right? So you can see how complicated this is getting. And I'll show you a little bit more of a teaser on how we're going to start actually using these insights to treat people. And just keep this in mind. In the next, I think, 10 slides or so, I'll show you this latest version of how we're actually going to be putting these insights to good use. And then just briefly, we can't do anything without data. So we can have all these ideas, we can have a bunch of biospecimens sitting in the bank, but without actually collecting information on people. This is a test screen of our database, for example, just for full disclosure of what this looks like. So we look at back in time often, and we will capture as much information as we possibly can, and then we can couple that with those biospecimens with the treatment context, and we can really start to then understand who's going to do well, who's not going to do well, and how to do better going forward. You basically have to make what we call retrospective models, looking back in time at how people have done, learn as much as we possibly can, and then try to declare what we think is going to happen in the future. And ideally, as I'll show you, is one of my passions is to develop a clinical trial using those insights to make people healthier, better with new treatments. It just takes a long time, a lot longer than any of us would like, and a lot more expensive, I know that. But that's how we're going to eventually get there for all these cancers and cracking these things. AI, of course, machine learning. I'm not going to talk too much about this. I'm very interested in using some of these things, but again, without having the databases set, without having the biospecimen set. AI, it's kind of garbage in, garbage out. If you don't have the right infrastructure in place, which we are rapidly building now at Roswell Park for the last 3 years, I've been helping with this. AI is really not as helpful as we would like, but once you have all the data in one place, again, secured, you can really use it to find new pathways, new interactions that have never been seen before, and that frankly a single human being is not capable of seeing. And so AI and machine learning approaches can actually dig back through, tests all these different models, multiple permutations, goes back and sees does the data that is coming in the future, for example, matching with what I predict is going to happen or not. And it's again this iterative process, this very prototypical precision medicine approach. It's coming. I do have a colleague in Denmark, for example, who was trying to predict infection risk in CLL and with having some success, but again, it's 10,000 data points, and they, even in Denmark, right, with a relatively homogeneous population compared to the United States, tons and tons of biological diversity, heterogeneity, lots of noise, if so to speak, in the data. So it just takes a lot of collaboration, a lot of effort, a lot of money, and of course, it's very few centers actually have these capabilities. Even done in an experimental fashion, let alone in practical application, but they are coming. So this is something to really stay tuned about, and certainly we can keep talking more about as we do better and better over time. Another really cool thing that's happening, again, kind of in the research realm right now, the validation realm, is looking at imaging, advanced AI-assisted techniques, and pathology slide scanning. So I mentioned, of course, the light microscopy. You're relying on a human being typically to look at and pick out small cells. If any of y'all have ever looked at a microscope, with enough samples over enough time, you'll probably not want to become a pathologist, as I didn't. Just kidding, but it's impossible, frankly, to look at millions and millions and millions of cells, and with high precision pick out small little tiny signals or small little changes in shape or size of cells, small little artifactual elements which may actually be real biological phenomic signatures, right? So basically they're now looking at ways to slide scan and look at imaging techniques and technologies and really extracting even more information that's really hidden from plain view, basically, again, using AI assisted technologies. I think one of my favorite potential applications, newer applications, is going to be identifying proteins that are expressed only by cancer cells and not by the vast majority of healthy cells. And that really gets into next generation treatment, right? So if you can target a surface protein that's only shown by your cancer and it does not hit any of your other cells, that's really that's the gold mine, right? That is the ultimate end product, if you will. That would be the cure for cancers. As a process, right? If you can identify these neoantigens, target all of them, not target healthy cells, talking very few, if any, side effects in theory, and complete eradication of all these cancers, right? So for me, that's the ultimate application, using AI-based technologies, lots of specimens over time, give it 10, 15, 20 years of, billions of dollars of research. I do think this is actually feasible to do. It's just going to take a lot of effort from all of us. And then just a couple examples of precision medicine approaches and how, for the nihilistic or the pessimistic out there, and I don't blame a lot of folks for feeling that way, but, why do I care? Why, we're talking about spending tons and tons of money, lots of scientific stuff, how does it really impact me? Well, it does. And I want to just bring in a couple examples, say in chronic lymphocytic leukemia. So CLL is, again, this is the most common form of leukemia, B-cell malignancy, has weird impacts on the immune system, considered incurable. And historically, it was treated with chemotherapy, taking someone who's already immunocompromised, making them more immunocompromised. It would not work very well for most patients. Really understanding why it doesn't work took 20 years of work that culminated in a couple genes like TP53 and IGHV, mutation status, for example, to really try to start picking apart who will actually even respond to chemotherapy. And then now we look at some of our targeted therapies compared to chemotherapies. And one of my favorites to use still clinically as a workhorse is venetoclax and venetuzumab, for example, many other drugs out there. But fixed duration treatment, 1 year of a pill with 6 cycles of an immune infusion of an anti-CD20 antibody called obinutuzumab, used for other blood cancers as well, things like follicular lymphoma. And chlorambucil was a chemotherapy, basically. And you looked at some of the data, right? And it doesn't take much to see the difference between the blue curve, which is targeted therapy based, and the red, which is chemotherapy. So basically more side effects for less duration of response, or actually survival. So you're actually seeing literally an impaired survival for people, right? Progression-free survival, excuse me. There actually is a signal of inferior overall survival. So people who historically were, say, treated with chemotherapy and then still had the ability to join the party, so to speak, with targeted therapies, there's actually still kind of a late signal, right, by causing chemo-related injury, higher risk mutations, for example, like TP53, and actually having a harder to treat disease in the future, worse outcomes in the future, and potentially more infection risk along the way as well. So again, just really trying to get rid of chemotherapy, right? I think we can all agree it would be lovely, and we're actually about there. So in CLL, we're about there certainly for CLL. Chemo was actually removed from a preferred option when I joined the panel 3 years ago, and then the first generation drug called ibrutinib, a little more toxic than some of the newer kids in the block, so to speak, has been downgraded again because we have safer second generation options driven by translational research. And then I'm not going to belabor this too much, but just suffice to say, treatments are so effective now. We start looking at not just the the clinical endpoints we all care about, right? Shrinkage of lymph nodes, normalization of blood counts, symptoms gone, right? Obviously alive without tons of infections or other cancers. And we now are trying to get greedier, right? So the better we get at cancer treatment, the more rigorously we can root out the disease and measure it, basically, and make sure we get rid of every last little shred of this thing if we can, safely. And these targeted therapies actually do a much better job of doing that than chemotherapy. And that's part of the reason why they're better, say for CLL. Now, where are we at for large cell lymphomas using targeted therapies? I'm not going to talk about the bispecific antibodies much, but they are also being studied in combination with chemotherapy still. But back to small molecule inhibitors, this is that Guidance 1 trial I mentioned, again, for the most common lymphoma in DLBCL. And this is actually just looking at those different molecular subtypes I showed you on the other screen and adding a certain drug. In this case, actually, it is ibrutinib with R-CHOP, for example. And then looking at things like lenalidomide or epigenetically active drugs or an EZH2 inhibitor for EZB subtype disease. And basically the cure rate, again, for a relatively small number of patients was 90%. And you look at historical R-CHOP success rates as far as cure after the frontline 6 cycles of treatment, is around 60% for advanced stage large cell lymphoma. So we're talking about 30, and you can actually see that here in the blue curve. It's literally the control arm. And you're seeing, 90% of people are cured, right? If you look at, again, this progression-free survival curve, as we all do, this is called a Kaplan-Meier curve, by the way. This looks at time on the x-axis and then the percent of success, and I would say maintaining a remission. You start at patients who all achieved a complete response, so it starts at 100%, and then over time there is a certain rate of relapse and badness that does happen. And of course, you want to see less relapses, less badness. So the higher up on the curve we are, the better. And so we can see the addition of a smart targeted drug to R-CHOP, granted with some more side effects, right? When you're adding more onto other treatments, you're going to get more side effects. So you'll talk about replacement of drugs or substitution and de-escalation, taking away drugs that you may not need. That's this incremental way we have to test new treatments basically in a clinical trial setting. And this is actually, I think, a randomized phase 2, I believe, with a phase 3 trial on the way, which is what's going to be ultimately needed. This is lovely, right? But why we're not doing this right now? And the problem is, again, relying on RNA sequencing techniques that are not really widely available. We're blessed at Roswell to have a panel in-house. A lot of other places have them as well, but then we have insurance companies, fighting us tooth and nail working on that as well. Right. So it's not commercially validated yet with a single assay. Right. So there's differences in the testing that can come into play, which can maybe call to question some of the generalizability of these results. Lots and lots of regulatory oversight, red tape, barriers, costs. So as you can tell, it's amazing, but it's not there quite yet. But I think it will be. And when you talk about adding, say, ibrutinib, which is a relatively quote unquote dirty old drug, to someone who's younger than, say, 60 or 65, with fewer risk of side effects in the younger age groups, um, it really becomes more appealing, right? Especially when you talk about subtypes of lymphoma that historically do the worst with R-CHOP. So, the ABC or non-GC types, which are treated with ibrutinib, for example, in this case, tend to actually do worse with R-CHOP. So, the Phoenix trial, just for reference on that, was one of those other things that people don't talk about, but it's something to pay attention to, right? Can we do better based on a subtype of disease? One of my number one enemies as a translational researcher is Richter transformation. This is a conversion of CLL into, say, a large cell lymphoma, 95% of the time. These are chemo resistant, so you can give, say, R-CHOP or even EPOCH or other heavy regimens, and only, say, 10 to 20% of patients actually get into a durable complete remission, say, at a year or two. Historically, 7% of people would be alive at 5 years. So really, really bad prognosis for most people. Some new insights, just to give you a flavor of what's going on out there in the world. Actually looked at things like single cell sequencing. I'm submitting my first specimens actually for this next week here at Roswell, but we can actually use some of these fancy RNA sequencing techniques, for example, on literally a single cell, and which cell is changed, which cell is not changed, kind of who's normal, who's not normal. And a Spanish group and a budding collaborator of mine, Ferran Nadu, basically deployed some of this technology, and they were actually able to go back at patients who ultimately had Richter transformation and had multiple biopsies over years. They actually were able to find a pre-transformed Richter, large cell clone, basically kind of nasty bugger, hiding in a lymph node up to 19 years in advance of transformation using these technologies. So it really begs the question, we always talk about, say, for low-grade lymphomas, this lifetime transformation risk. Can we do better, right? Can we do better than just this broad population-based? In the case of Richter's, it's up to 12% lifetime, about 20% or so for 15 to 20% for, say, follicular lymphoma, right? Can we do better rather than just saying, yeah, we don't really know, we're just going to watch you and wait, right? But maybe we could actually find those transformed clones in advance. So that's coming. There are also subtypes of, even within a rare disease now, there's emerging subtypes of disease that we can potentially act on, but again, hard to generalize. Going back to new treatments, and there are new protocols basically now that are loaded with targeted therapies and actually are now chemo-free, including for Richter transformation that's clonally related. So it's just, I won't bore you too much with details, but it's a different thing than a non-clonal large cell in a patient with CLL that you have to treat really more like with chemo. But there are actually these chemo-free approaches as well, say with a checkpoint inhibitor, a BCL2 inhibitor, and an anti-CD20 monoclonal antibody. I found this paper, we put it up on the NCCN guidelines, it's now on our guidelines. And then new combinations, of course, all the time, new treatments all the time. I'm blessed to have my first trial that I wrote myself opening next week. It's using this next generation BTK inhibitor called a non-covalent BTK inhibitor with a checkpoint inhibitor. It'll be the first such combination, and hoping to get at least 70% of people to respond where they, other prior treatments may have failed them. I mentioned CAR T, I think, a couple times. So what the heck is a CAR T cell? CAR T is it's been the future for the last 10 years or so, really 12 years. These are called chimeric antigen receptor T cells. This is a way to basically take a normal T cell, which is supposed to turn on only when you have other immune cells kind of present a bad guy antigen or bad gal, a nasty protein, for example, that's found on a cancer cell, brings it to a otherwise kind of normal T cell, and then it turns it on that way, kind of a multi-step activation process. CAR T cells are actually engineered to be switched on from the get-go, and they basically, we will engineer these chimeric antigen receptors to hunt a target of our choice. And the most successful so far commercially and in the real world has been CD19 on the surface of B cells. The first approval was over 5 years ago now, almost 6 years ago on Zuma-1. Looked very promising, right? Most patients, if you look back at historical outcomes, say with the Scholar-1 registry, it's called, 90% of people would be gone, unfortunately, after a relapse of large cell after 2 years. And now we've at least raised that bar up, pretty significantly, but not where we want to go, right? I don't know about y'all, but when I was in medical school as well as middle school, if I had 31% of my test, I would not be very happy with that, right? So a lot of work to be done, still quite toxic, but very, very promising as it, this is really the second generation of CAR T cells to even be investigated. And, again, it's doubled the chances of being alive when you measure it out to, say, 5 years. Some barriers, though, of course, there's toxicity, there's cost, there's logistical problems with these treatments. CAR T cell therapy really it costs like $450,000 to get through a whole course of treatment. I think it's money well spent when you're talking about someone who's otherwise going to die from lymphoma. But certainly we can make them cheaper, better, safer, quicker. We always want more of everything, right? But I think at least better and safer. I'd take that any day. We also have no way to currently, and I've been talking to some industry partners, all these disclosures. I always want to see what's behind the scenes, and I talk about some of my ideas. But there's no way to actually track CAR T cells per se, at least that's approved. And there's no way to really measure the health of those T cells. Again, in the commercial setting, we have some evidence of our own, which we're putting out there. But there's no actual readily available tool to track the health of a T cell. And even our approach is still very primitive right now. So but look at, say, Richter transformation marginal zone lymphoma. This is my poster from the tandem meetings last year. We're finding basically that certain patients will do really well with CAR T. And we actually showed that even Richter transformation, again, 7% would be alive, say, 10 years ago after just chemotherapy. With things like CAR T cell therapy, we've gotten it closer to the large cell overall group, around 30 to 35% of patients still in remission with a chance of cure. This is the overall survival curve, but we also have progression-free survival here. Unfortunately, you can see they're very similar, right? If you progress with a nasty lymphoma, that's by far the biggest risk of dying, right? So preventing relapses, identifying them earlier, better treatments, all the time. But again, our goal is not to be here. Our goal eventually is going to be that 100%, right? No one's left behind here. This is my other humble brag, so to speak. But this is something I'm working on publishing actively right now. But this is a slide that I presented at ASH last year, one of my 2 oral presentations. And we showed that transformed follicular lymphoma, for example, has a much better prognosis with CAR T compared to, the non-transformed, we call it de novo diffuse large B-cell lymphoma. Many more people are alive and not relapsing with this subtype of lymphoma. And it begs the question, why? And that's active areas of research right now, trying to break apart as we study some of these treatment outcomes, again, with data, with follow-up, and then with some biospecimens, putting them together. Who does well, who does not do well, and why? And that's, we're learning all the time. But again, even transformed follicular, not 100%, right? We got some work to do. So MRD, again, just briefly, I just want to share with y'all that there are some FDA-approved options for measuring disease in the blood, for example, or even off-label, so to speak, in the central nervous system, like CSF fluid. So a lot of companies will actually accept some of those samples if you ask them enough. And nicely enough, what we do with it is still very much up in the air. I think we'd all at least say we could augment surveillance to get sooner scans, closer visits, et cetera, if things are positive. We don't have approved treatments yet for, say, a large cell lymphoma with minimal residual disease positivity. But that's coming. So just know that these tests are out there. They're confusing, frankly, still, but as we get more and more familiar with them, with more and more data, validation, we are going to start developing better ways to use these tests, and just know that they're out there. So things like You got the next slide. It's this company called PhaseSeq, for example, is testing it. clonoSEQ, through a company called Adaptive, is already FDA approved for this as well. Natera, there's a whole bunch of companies that are working in this space very, very actively. And basically, you're trying to predict, if your blood test is negative, are you going to stay in remission? If your MRD is positive, are you going to relapse? You can see that there's still false negatives here, and there's false positives here as well. So just know, again, 20% on either side is not 100%. You want to really see a perfectly discriminating curve with lots and lots and lots of patients and lots of treatment contacts. So again, it's a great start, but we're not there quite yet. And just know that it's something that's available, but it may or may not be helpful. It may actually be anxiety provoking for people. And that there's kind of a mixed bag of opinions out there as far as certainly providers go, with more to come. And then I'm going to wrap up a couple more slides. I'm sure I'm over time. I apologize. But trying to identify, for example, some of the worst outcomes in advance. Again, trying to look for patients who are at risk, say, for a relapse, God forbid, in the brain, right, or in the spinal fluid. There are many, many new treatments and new tests that are out there to try to predict that horrible fate. This is, say, the Marietta study, right? When you see people who had such nervous system involvement from the very beginning, got treatment for the nervous system involvement, went through auto transplants, were still fit, to go through all these kinds of treatments. Still, most folks were actually relatively young. Despite all that treatment, still only 60% of patients are still in remission. And then if you look at folks who relapsed after they got their frontline treatment, the outcomes were even worse, right? Only 20% of patients, made it past 2 years before relapsing. So it really shows us that we are missing, despite some of these clinical risk scores, like the CNS IPI score, for example, or giving little injections of methotrexate or cytarabine, and it can delay progression, but it may not prevent or cure and completely protect against those devastating problems, right? People can come in having gotten through 6 cycles of treatment, feeling good, and then 6 months later they have stroke-like symptoms, big mass in the brain, horrible stuff. I do think there's been enough data so far to suggest that using our new techniques, again, precision medicine approaches, our best molecular tests, we can actually start to discriminate who's going to have that problem and who is not. And that's something, again, of active research for us as well. We're trying to lead on this. This is my number one of my other enemies, frankly. We've got a lot of enemies as a cancer doctor, but this is one of them. This is I hope the last time I'm ranking on my slide, but this is something that we're very proud of at Roswell. I'm part of a lab, and we're presenting basically how certain treatments, like in our case, it was venetoclax for CLL, can actually repair the immune system. And we're using our knowledge of small molecule inhibitors and other treatments and the best sequencing of treatments to get people their best outcomes, say with CAR T-cell therapy. I had the privilege of presenting in San Diego. I also met Charles Barkley. First time I ever met like a real celebrity in the Buffalo airport, actually, as I was flying out to San Diego. So it was a complete dream. But we're showing that some of these other treatments can actually improve the immune system. And another one for CLL is actually ibrutinib. Pre-CAR T can improve outcomes, double the overall and complete response rates. Brand new data there for that. So it's very exciting to be part of research programs like this. And this is a sneak peek. Please don't share this. This is in our draft manuscript. We're getting this out very soon, but just suffice to say our multi-omic approach. We do whole blood PBMCs, and or peripheral blood cells, basically, and look and see who's changing and who's not changing. And then we actually look at all these different data elements together. And we're really trying to do a multi-omic translational research program, again, from patients who are lovely here at Buffalo, and they've donated their blood and their data, of course, secured. And we're basically mapping how the immune system changes with, say, a small molecule like venetoclax and lots of others, with some potential to help boost immune responses, have better synergy, better treatments, and at least a better understanding of the disease itself and why it may not be dying away with treatment. So lots more to come. We're showing macrophages are improved, T cells are improved, Just if nothing else, highlight that CLL is a very immunosuppressive, nasty disease, and that we've just beginning to scratch the surface on the immunology on how to get rid of that thing, right? As with other lymphomas. I think another extremely exciting part of future-focused lymphoma treatment is also leveraging our insights on how the immune system talks to other parts of the immune system, especially when you're talking about engineering cells like CAR T or bispecific antibodies. Rational sequencing of treatment. So, I may not want to give, say, bendamustine to somebody before they go for a CAR T cell therapy, if I can get away with it, or at least collect those T cells first, because we know that bendamustine is going to really sock those T cells in for a year, right? It may make worse CAR T cells. So we're really learning a ton, and I don't want anyone listening to give up hope, right? That you see all these old data, these old curves, and think that that's going to happen to me. But the more we learn, the better our outcomes are going to be, and the more hope we have, and the more treatments we're going to have available. Again, iterative process. It's going to take time and lots of participation from lots of people. And then last but certainly not least is T cell lymphoma. Again, another one of our enemies here. Very tough to treat for many people, many patients. A lot of folks will either have outright chemo resistance to frontline treatment, say like with CHOP or CHOP-like treatments. And then there's actually no CAR T cells available yet. There's one that was just published, actually a couple published. There's a CD7 CAR T and a CD5 CAR T. But part of the problem is when you have a T cell that's trying to find other T cells, you can actually kill yourself, so to speak. So you actually have to edit these CAR T cells to drop whatever marker they're trying to be hunting for. So, for example, at WashU, they just published their work in Blood, I think last week, George Wee et al. And basically, it was CD7 was engineered out of the CAR T cells so that you're not just self-destructing, right? Otherwise, you're just going to blow up your own product, basically. So very complicated, but gene editing techniques, looking at new epigenetically active drugs, how those can rewire the immune system. Things like HDAC inhibitors, for example, have been tried for a long time with some success. Lots more work that needs to be done. So just know that there is still a lot of hope out there, even for things like T cell lymphomas, and there's new consortia. The one that I really like a lot is just in its infancy. It's called the PETO Consortium, and it's looking at some of these relapse refractory T cell lymphomas. And a lot of us docs around the country and the world are trying to pool our brains together to really crack these things into oblivion, hopefully, and help people. So in conclusion, precision medicine, I think, should enable more cures for more cancers, and more, I should fix that, in more tolerable and effective treatments. Multiomics and other molecular techniques and bioinformatics, dumping all these things together into one holistic model are already illuminating, how the body reacts to treatments and how new other treatments can be basically repurposed or releveraged. Even things like ibrutinib I mentioned can help improve CAR T cell efficacy and outcomes for patients with CLL. Just one example of many of ways to kind of recycle some of these old drugs that may have kind of lost their luster because of toxicity concerns, reasonable concerns. We might be able to repurpose some of them actually to do even more good over time, and of course find new drugs as well. We need data, we need participation, we need to be collaborative with each other, and of course keep us honest and ask lots of questions. AI, machine learning, there's all this buzz out there. I don't think it's going to replace my job tomorrow, but I do hope in 10 years I can help it replace my job because cancers are gone. So we'll see. But it's not easy, right? As you can tell, and there's always going to be a need for more improvement. In the future, I would say is almost here. That dream of those neoantigen-based treatments, right? Personalized treatment with no side effects, for example, and cancer's gone, poof. It's at least I have a vision for that. I think it's at least within the realm of possibility here. And with that, I will conclude. I'm sorry for going a bit over here. I talk a lot.
That was great. Thank you so much for that wonderful presentation, Dr. Cortese. It's definitely really exciting to see all the research being done in lymphoma and potential future opportunities in this space. But But yeah, so now it's the time for questions. So if you have any questions, feel free to drop them in the chat. We might not be able to get to everyone's questions today, but we'll try to get to as many as we can. So our first question is there research being done on treatment options for patients who relapse after CAR T therapy?
Absolutely. So CAR T cell therapy, unfortunately, right? It's we're talking 30 to 35% of patients are going to stay in remission. This is again for large cell lymphoma. Transformed follicular is much better, but yes, so absolutely critical need for that. Um, One of them is just to look at what's the best sequencing of treatment. So we have some papers we submitted for ASH this year. That same CAR T consortium that kind of found that signal of transformed follicular. In my case, again, I'm just one guy, but showed that bispecific antibodies actually are more effective before CAR T, not excuse me, more effective after CAR T rather than before CAR T. And we talked to a lot of industry partners as well, trying to get insights. Um, that's just one example though of sequencing of treatment. There are new combinations, say of bispecific antibodies plus antibody drug conjugates. There's new generation, second CAR, third CAR kind of trials out there. There's allogeneic or off the shelf CAR T cells out there. They're not persistent enough, unfortunately, quite yet. I didn't even talk about those for this because they've been out kind of at least a signal of efficacy for 5 years or so now, but they've not really been shown yet to be better than bispecific antibodies, for example. So in the early post-CAR setting, I'm always looking to see, do I still have circulating CAR T cells that are just tired and exhausted? Can I, re-energize them? So yes, there's other things like BTK degraders, there's MALT1 inhibitors and other small molecule inhibitors. There are central nervous system lymphoma treatments as well, like we have an IRAK4 inhibitor with ibrutinib of all things. So there's new targets. I think we're still lacking, frankly, a lot of these really new novel treatments. Like there's an ROR1 alpha antibody drug conjugate, zilovertamab, for example, looks good in combination. We're actually going to study it frontline for large cell lymphoma to try to take on polatuzumab vedotin with RCHP for GC type large cell only, because in non-GC it looks like pola is better. But these are, again, they're still some time away, and we need more of these options, frankly. That's why we do this, what we do, frankly, with translational research. We're trying to find those new targets, those new, what makes those cancers tick? Can we use chemo-free approaches, say for Richter transformation? So the other thing is it's really important to know the disease fundamentally as well. So is it, a relapse, say, of follicular lymphoma with options like zanubrutinib and obinutuzumab still available, the bispecifics available, tazemetostat. Plus, I didn't even talk about that, but we have another trial that we're opening from my buddy Sam Yumshone, went from Weill Cornell, he's going to NYU, looking at tazemetostat as an EZH2 small molecule inhibitor with a bispecific to actually, again, re-energize the T cells and make them work better in combination and kick them back on, start, again, getting the anti-tumor responses back. The venetoclax-based treatment, we're really trying to hone in on that part, that small piece of the puzzle here to see if we can add that in combination with other treatments, for example. So it's a matter of like repurposing what drugs we have, but in my opinion, it's definitely an unmet need still. I mean, if you look at even our data, it's like from last year, patients who progress after CAR T, their outcomes are still very, very poor. And we have a lot of work to be done in that space. And we're not even close.
Thank you for that answer. And then our next question is it worth doing NGS testing before deciding on treatments?
My bias answer is yes, but I also have the luxury of, our in-house panel at Roswell is only $400 out of pocket. And don't tell my leadership team I said this, but we tend to, if we can't get insurance to cover it, we tend to just write it off. It's such an efficient, streamlined kind of system. So we probably overtest, frankly, with NGS. That said, though, for me, it's always follow the NCCN guidelines, plus whatever's been recently published in kind of lectures like, just like mine is one example, but always staying tuned. So short answer is yes. I think it's a must for CLL and SLL. It's a must for mantle cell lymphoma. It's a must for relapsed T cell lymphoma. Honestly, any relapse of lymphoma, I would argue, is a basis for NGS testing. Say in follicular lymphoma, you're looking for EZH2 mutations. Even in the frontline follicular lymphoma setting, though, there's like older risk scores like mFLIPI7, which actually used sequencing results to try to predict time to progression. Say it was actually with R-CHOP for that particular study. VR kind of annihilates all those, obviates the need for testing for a lot of those treatments, or excuse me, for a lot of those mutations rather. Um, so it's a complicated answer. My answer is always yes, at least talk about it. Certain cancers, it's a must. Mantle cell is absolutely a must. CLL, I would argue, is still a must, even though a lot of our treatments will overcome TP53 mutation, because you're trying to predict the future. You're trying to see, number one, am I getting the best treatment? Do I really know my disease well? Right? With large cell, even I'm working on this as well, kind of at least part time, but I'm trying to use our old NGS data, for example, from our large cell specimens to go back and see if I can do a best fit pattern, for example, in those 5 subtypes I showed you, the molecular subtypes. You can even make some inferences there. We can't add, say, like at least I would caution against adding other drugs like the Guidance 1 trial in advance of a readout of that full trial, but that's something else that's coming. So short answer is talk about it with your doc, look at the NCCN guidelines, especially the ones for patients. And then if there's ever any uncertainty, I would always say yes. But again, I'm biased and no insurance companies are a pain in the butt. And it's not always cheap and quick like I'm blessed to have here. So
Thank you. And then our next question is from someone whose daughter was diagnosed with mantle cell lymphoma. So she's on a
Mhm.
BTK inhibitor and would follow with CAR T therapy. So do you know of any research being done in mantle cell lymphoma?
Absolutely. So I'm the site PI for a BTK degrader. So there are covalent, non-covalent BTK inhibitors, right? So there's the covalent ones are actually now frontline treatment. This is a relatively new change from ASH 2 years ago. So it was like the triangle study, and then that was ibrutinib plus R-CHOP with HiDAC basically, or excuse me, the RDHAC. And then it was looking to randomize, to transplant or no transplant, and basically showed that the BTK inhibitors, especially when given frontline embedded into RMA with that kind of an approach, fit young patients, under 65. You can actually get away without the transplant. I would use NGS-based MRD tests though along the way to see how good of a remission we've gotten into. We've actually shown, it was the Alliance trials actually showed that if your patients are clonoSEQ negative, can't find any residual disease with mantle cell, for example, in the bone marrow, 0 sequences detected. There was no role for autologous stem cell transplant, for example. So those are shows you some of the power of these MRD tests. So that's research that's fairly new, I would say. Then there's a couple trial updates. Zanubrutinib is, I believe it's officially approved now for mantle cell lymphoma, certainly for marginal zone lymphoma. I saw that was in there as well. But the BTK degrader is one of those new classes of drugs which have a lot of promise for people. And basically, it takes, instead of just blocking that pathway, either directly, covalently, irreversible binding, or reversible binding, it actually takes the whole thing and throws it right in the trash, like you crumple the piece of paper. Instead of crossing out, X's on your figures or whatever, you're just taking the whole paper and throwing it in the garbage. So that's a promising approach. But the mainstays still are BTK inhibitors and then using immune therapies. I really am frankly excited about bispecific antibody combination treatments, especially post-CAR, and getting people really into the best possible remission pre-CAR. So there's also combinations of like non-covalents with venetoclax, pirtobrutinib and venetoclax is one I'm, for example, really paying attention to. I've actually used it on a couple of patients, including one gentleman who had 9 lines of treatment for mantle cell lymphoma, got into a complete remission through CAR T, doing fantastically well now, right? Chemo-free, chemo-like kind of approach. But those are still in phase 2 studies. That was, I think, Michael Wong's group. I caught wind of that, at least saw it safe, right? Offered it compared to, say, DHAC salvage chemo that I knew was not going to work very well. There's lots of hope in these new combination treatments. So I hope I answered that question partly, but basically it's there are new drug classes. Then there's the really, I think, more excitingly, perhaps more excitingly, are new CAR T cell therapies and actually new combinations. I think the antibody drug conjugates with bispecifics, things like mosunetuzumab, polatuzumab, for example, just one example, are showing a lot of promise in that space. The ROR1 alpha, like Zillow, for example, had a little bit of activity as well. It's not great, but in combination could be even better. So complicated, we're not there yet. Clearly, there's lenalidomide that's still out there, right? That's still very, very effective for a lot of people for years. And I've had a guy with, can't say too much detail, but end organ disease, right? Lots and lots of comorbidities on just regular old lenalidomide, for example, for years at this point with mantle cell. So they're coming. I still think I would challenge our pharma colleagues if they're listening. We need more. We need more targets that are novel. We need more funding, frankly, for translational research efforts, and we need really more of everything. To be honest, it's most patients do well for years, but I sleep fine generally, but I don't sleep well for my patients who I know I don't have as many options for, especially if I'm running out of options, right? And for my own practice, something I would encourage every oncologist to do and every patient to ask, if you're so inclined, is ask what would be my next 3 lines of treatment, for example, to your docs, right? If we don't have 3 lines of treatment, at least a clinical trial that's readily available in your region, available to you. If your doc is not there yet, I would always advise another opinion. First of all, especially for a center that has, say, an active clinical trial. Not every center is going to have clinical trials available, number one, for a particular disease group. A lot of clinical trials exclude patients, say, with central nervous system involvement, or any kind of meaningful comorbidities or medical problems, right? So always, I think, look at clinicaltrials.gov and ask your docs, like, hey, doc, if I had a relapse, if I relapse 2 times in a row, how are you going to treat me? And we've got to be rattling off, multiple lines of therapy and salvage options, and better feel fairly routine. If not, I mean, your doc could be having a bad day, but I also would say it's never wrong to at least get another opinion. You don't have to. I wouldn't shop around for 12 opinions and never do treatment. That's not a good idea. But I think it's prudent at least to listen to your providers and care team and ask them, if God forbid I relapse, what's next, right? What will be your plans? And we should be receptive to that, I think, as docs, and if it's a short leash, right? Say, oh, I've got 1 or 2 lines of treatment. I'm looking at clinicaltrials.gov and I'm actually referring my own patients, right? If I'm being responsible, that's my job. And I expect that, frankly, of all my colleagues around the country. We work together. Anyone who's like, don't get another opinion, not worth your time, I would worry about coming across docs like that. They're certainly out there. But again, I think another opinion for multiply relapsed disease is always a prudent thing to do. It's never wrong.
Absolutely. No, these answers are super helpful. And I know we're over a little bit. Do you have time to answer another question or
Yeah,
two?
I think I'm good till 2. I'll make time.
Okay. So our next question is, you mentioned this a little bit already, but is there research on treatment for marginal zone lymphoma?
Yes, there is. Again, it's kind of lagging behind a little bit. It's less common, for one. So CAR T cell therapy is almost, I keep hearing it's almost going to be approved. It's under consideration for marginal zone lymphoma. Certainly transform marginal zone lymphoma. Our data from Tandem, we had, I think, 25 patients at 14 centers treated. Half of them are still in remission at 3 years. So I think CAR T, whether it's approved or not, would be something that's certainly worth asking about and trying to get approval for multiple relapse disease. Generally, though, marginal zone lymphoma, Rituxan works, but I also just saw the question about the marginal zone in the lungs. I always look for other causes, say, of persistent disease. So marginal zone lymphoma specifically, this is a little bit of an aside, tends to be addicted to NF-kappa B signaling. So it's actually it usually arises in the setting of some kind of chronic inflammation, not always, but things like weird infections, God forbid, another cancer. I've had a couple patients who had marginal zone lymphoma in the lung that had a lung cancer. So tissue biopsy or at least less invasive, kind of pan cancer screening, liquid biopsy techniques. I always would encourage. Um, you can also see some lingering treatment effects, actually. Just answering the PET scan question, it doesn't always means there's viable lymphoma. Sometimes you're actually seeing the immune cell infiltrates, mopping up the disease, and those T cells and macrophages sometimes can also take up some sugar, right? And just to be mindful that it's, I would pay close attention, at least get another short interval scan to make sure things are getting better. And then you can start ratcheting up pressure. We often give things like, BR, there's bispecific antibodies again coming for marginal zone lymphoma. BTK degraders are also looking very good there as well. We have a MALT1 inhibitor, for example, on trial, which is also looking fairly good so far. And then the bispecific antibody ADC combinations again are coming for marginal zone lymphoma. So generally speaking, the vast majority of people with marginal zone lymphoma we have, and then of course lenalidomide-based treatments we do have options for. But yeah, and BTK inhibitors, of course, are part of the mainstay there as well. But there are not. I would love to have 50 drug candidates in the top of my head. I have like 10. So there are some out there, right? Some novel mechanisms of action. Like there's a super steroid, for example, that's supposed to target CD20, like 1,000 times more potent than a regular steroid, kind of a thing. And that's a new way of killing. So we talk about a new growth pathway, right? Like we talked about like the electrical wiring, so to speak, of the cell. We talk about new surface proteins, and then we talk about new ways to reinvigorate the immune system. Basically, those are the kind of the three main ways we look at these lymphomas for treatment. But yeah, marginal zone lymphoma, it's getting there, but we're not. There's nothing I've seen so far. I mean, ASH is every December, so this video should be obsolete, I hope. In really, it's actually November 5th. You're going to see results published on the ASH, the American Society of Hematology website. And then you'll see presentations in December. It's actually in Orlando, Florida this year. So if you need a trip to Disney World, want to see a bunch of nerds like me talk with some of the new treatments, that's where you're going to see those releases basically coming out. So stay tuned to that. I'll have a moment on that though.
Perfect. And then another question is, do you expect that we'll have some medicines that could potentially cure CLL in the future?
So I'm working on it. There's biological cure and functional cure, right? So what I mean by that is, biological cure for me would mean there's zero evidence of disease anywhere in the body. If you were to morbidly, in my thought experiment, puree somebody, right? Do single cell sequencing in their entire body. You can't find a single cell left over from the disease. That would be the biological cure. The functional cure would be this cancer never causes problems ever again, right? And let's say, venetoclax-based treatments are still the mainstay. We're learning a lot about how ven, in particular, rewires the immune system. But long story short, it takes an immune-focused approach to cure CLL, and CLL does not want to be taken out by the immune system, right? That's something that we're actually actively trying to address. So CAR T cell therapy, for the moment, besides an allogeneic stem cell transplant, are the only possible ways at the moment to get to a biological cure. And the rate of success is still fairly small, right? So you look at, say, lisocabtagene maraleucel. This is the registrational study that led to its approval in CLL, and they're validating that it's still working as well as the trials, right? Transcend CLL 04, 40% overall response rate, 20% CR rate. Ibrutinib doubled that actually for each, right? So it's about a 45% CR rate, almost a 90% objective response rate actually. So that just tells you again that rational targeting of the immune system using other drugs to improve upon each other, right, with better synergy. That's where I think the cure is going to lie. Venetoclax-based treatments, though, can be so effective, especially someone, say, in their 70s, 80s with lower risk disease. Put someone through a year of treatment, oftentimes they will never need treatment again. They can be functionally cured. So it really depends on the context, molecular subtype of CLL. But ultimately, it's going to require a little bit more creativity on re-engaging the immune system. to mop up any residual disease. I actually have a couple trial concepts out there that I'm working on to get over the finish line. It's like MRD positive disease, use other treatments to knock that thing out basically safely, as safe as you can. So just to clue you on that, so I'm looking at say bispecific antibody therapies for CLL, which still are more toxic and less effective in CLL. Say with venetoclax, as a mop up kind of treatment after most of the CLL has been melted away. In those kinds of treatment settings. So it's complicated. We're waiting for a lot of these other trials to read out, right? There's a lot of safety data, dosing data. We frankly rely on pharma companies more than I'd like, to be honest, to get some of these new drugs in development. I'm working on ways to get our own drugs through the pipelines, our own CAR T cells. I think we're actually going to be better at than small molecules. So it's coming. It's active research right now, but it's slower than we all would like. So I see a curative approach for CLL coming, but for the masses, so to speak, without CAR T, it's going to be a while. It may be a long time. A lot of my elderly colleagues think that it cannot be done, but I said challenge accepted. So
I love that. Thank you. And then one really quick question before you go. I think this is a good one to end on is just, do you have any advice or thoughts that can help patients stay hopeful while we wait for this research to advance?
I would say like HealthTree, honestly, like your organization is wonderful. So staying tuned in the broader community, talking with each other. I had the privilege of being our captain at Roswell for Light the Night. It was Blood Cancer United's rebranding as well. So a lot of these organizations, HealthTree, you're my faves, right? Let me put it that way. So, and there are many more organizations out there, the NCCN guidelines. Stay active, ask questions. If your doc is just not cutting it for you, you're having side effects, you're not feeling heard, doesn't have a plan, God forbid. Like most doctors, I think, are wonderful and certainly love and care for their patients, but every once in a while, there's, I have bad days, and there are other folks who are just not doing it. You can always look and ask for what else is out there, right? And clinicaltrials.gov is one way to do that. These are registered studies that have to go through the FDA, right, to even be considered for eventual approvals down the road, for example. That's always an updated repository of information for new clinical trials. And we're getting much, much better at treatments all the time. And, I've not had a cancer. I've lost friends and family to cancer. I had one of my football teammates, not to get too personal, but one of my fellow offensive linemen in high school died of lymphoma. And now our new treatments, fast forwarding 20 years, would have cured him, right? So the more you can kick the can down the road, stay active, advocate for science, advocate for each other, work with your team, stay physically active, spend time with your friends and family. As some older mentors used to say, I never liked this, but none of us get out of here alive, right? So enjoy your life as much as you possibly can. There's tons of survivorship resources out there as well. Like at Roswell, for example, there's free massages, yoga classes, nutrition, coach programs, right? There's a lot of resources out there if you just ask your friendly cancer center or your doctors, and we're all here to help you. We're not quitting, put it that way either, despite some of the challenges to science and funding cuts. I'm still here. So, and a lot of my colleagues around the country are too. So stay strong.
Perfect. Thank you for that answer. And thank you so much for staying over and answering all these questions. I dropped my email in the chat, so if we didn't get to your question, please email me and we'll work to get those answered. But yes, thank you so much for that wonderful presentation, Dr. Cortese.
You're welcome. Thank you all.
Real quick before we go, I just wanted to highlight a couple of our upcoming events. So this Friday we have an event about finding strength after setbacks. So this is going to be stories from relapsed and refractory blood cancer patients. And then on October 7th, we have a webinar. It's our bi-monthly blood cancer financial Q&A. And on October 8th, we have a podcast coming out about the latest research for mantle cell lymphoma. We also have a number of upcoming in-person events. Connect to Cures allows you to connect with other patients, learn from doctors, and discover resources in your area to help you navigate your cancer. If you're interested in attending any of these events, the QR code is on the screen to register. And I will be at the events in Vegas and Brooklyn. So if you live around those areas, I would love to have you come and meet you in person at those events. And before we wrap up, I just want to say a huge thank you again to Dr. Cortese for that amazing presentation, and a huge thank you to all of you for being part of our lymphoma community. Your support means so much, and we are so grateful to have you here. So I've included my email on this slide as well. Please don't hesitate to reach out with any questions, and I look forward to seeing you all at another webinar soon.
Have me. Good day, y'all.
Thank you.